presenting on elevated PSA and obstructive LUTS. These are my disclosures. So as we already know, we know BPH is the increase in the number of prostatic stromal cells, epithelial cells, and obviously hypertrophy is the growth of these cells. I think what's important for us to realize is that PSA is exclusively secreted by the prostate. So other than the prostate gland and Cowper's gland, but that's really where PSA comes from. And obviously PSA is extensively utilized in prostate cancer, but in BPH it does play some roles as well. And I think where it plays a extensive role is it can help us guide our patients and also counsel our patients in terms of predicting those who may go on to have more progression of their symptoms. So the first thing we're going to look at are some population-based studies, one in Olmsted County and one in Crimpen. These are some older studies, and what we look at as a natural history. And what's interesting is when I was doing this or preparing this talk, I realized how little modern data we have on natural history of avoiding dysfunction. And it's a significant gap in our literature. So we sit here and talk about a lot of these novel technologies, but in a lot of ways, we don't have a lot of data on natural progression. So this is a study from Olmsted County looking at 40 to 80-year-olds. Patients completed a IPSS at 3 contact points for up to 4 years. And what we learned from that is that there's an increase in IPSS by 0.2 per year. And the most rapid growth really occurs in 60s to 70s. So the idea is that patients who present in their 40s typically can have more spaced out follow-ups, but those who get older probably require more frequent follow-ups so patients don't end up in urinary retention or progression. So from this study, what we learned is that in the follow-up of 6 years, peak flow rates declined by about 2% a year, and independent predictors of more rapid decline was a baseline Qmax of less than 10 and age greater than 70. Obviously, benefits of this study: large community study with excellent follow-up, highly relevant to us in this room, and a practical management of guiding our patients. So when patients come in and go, hey, my symptoms are pretty stable, what does this mean? It's a way for us to explain to them where they're likely to have natural progression. And the big thing that's really important here is that symptoms are present for a long period of time. And as Kevin mentioned in his talk, we've got this large growing population, and age is probably the largest predictor of BPH. And symptoms do get progressively worse over time. Another study that's equally as important is a study from Crimpen, which basically also added on PSA as well, where they saw an increase in symptom severity, and they also saw that a more rapid rise of PSA levels correlated with prostate volumes. And ultimately, if you track PSA, there's a twofold increase in symptom deterioration as well. So looking at this more closely, we're looking at obviously these community-based studies, which is Olmsted County, Crimpen study, but another place for us to look at where PSA and other factors can play a role, the MTOP study, PLES, and ALTA study as well. So benefits of looking at these studies is that the placebo arm of the clinical trials have lower risk of BPH progression. You do see deterioration in peak flow. One thing to keep in mind about when we're looking at placebo arms, so we have to look at some of this data with a grain of salt, is that there is a regression to the mean. If a patient gets a re-intervention or a patient has a change in management or they fall out of the trial, we lose that patient, so their data is censored. So we have to look at this data with a slight, with some more scrutiny though. So looking at prostate growth, so if you look at 3 different groups, if you divide it by prostate volumes of about 30 cc's, 25 cc's, and 22 cc's. What we learned from this is that patients with higher PSA, so a PSA greater than 1.1, has the highest growth rate. And we look at average growth rate per year, it's about 2.2%. So PSA is a great thing to invest in, right? So we know there's natural progression, and patients do get worsening symptoms over time. And those with larger prostates or those with higher PSAs tend to get more growth than those with smaller prostates. So when patients come in and we say to their PSA, yes, you don't have cancer, you're not likely to have cancer, we are also able to guide them a little bit further and mention to them, hey, your PSA is around 0.9. So the chance of this progressing over time is pretty low. And those with higher PSAs, like those above 1.5, are more likely to progress. So looking at the controlled trials in finasteride, and I won't bore you on details for the sake of time. We look at the PLES trial. One thing we learned here is, again, look at baseline PSA and annual growth of prostate over time. So again, PSAs that are greater, like those that have a baseline PSA greater than 3, are more likely to have more growth of prostate over time. And those who have PSAs greater than 1.7 are at an 11 times higher risk of acute urinary retention. So the PSA can be helpful in determining patient's progression. So looking at the MTOPS trial, we'll just focus in on the top, the PSA, and we can see that a PSA greater than 1.6 has a higher risk of acute urinary retention, and these patients can have up to an 11 times higher risk of acute urinary retention. So obviously other risk factors, and what's correlated with PSA is prostate size, is prostate greater than 30 grams as well. So to summarize, looking at PSA, PSA greater than 1.4 is correlated probably with a prostate volume around 40 cc's and is a pretty sensitive marker for those at increased risk of BPH and acute urinary retention and progression. So very helpful for when we're seeing our patients. We go over their symptom score, their Qmaxes, but also reviewing their PSA in detail can also be helpful in counseling patients for those who are likely to progress. So we have the BPH size, Qmax less than 12, AUA symptom score in the moderate to severe range, age, so obviously older patients are at higher risk for BPH and acute urinary retention, and a PSA greater than 1.7 gives you an 11 times risk of acute urinary retention. So factors that progress, we've actually covered this. So other studies that have been done. So I tried to find as much as I could on modern literature on PSA and prostate volume. It was interesting to find that none of these studies were based in the U.S. Most were based out of the U.S. But again, they actually validated some of the findings that we have, which is they have a cross-sectional analysis of 92 men, mean prostate volume about 60 cc's, and you saw a prostate volume of, a PSA of 4.2 with a range of 3. And there's a positive correlation between prostate volume and serum PSA, which we know. This is a retrospective study from Trinidad looking at 350 charts where they looked at age, PSA, IPSS, and ultimately they found that age is the biggest predictor for both values. So age is the largest predictor for both IPSS and PSA, and there's a correlation between IPSS and diabetes. But that looks more like a potential confounder, but the idea behind it is that age is your largest predictor, and so is PSA. Another thing that Kevin had brought up during his talk was looking at glandular content of prostate. So where PSA could also play a role is that when we have our prostate volumes, right, and we have a PSA and we're able to calculate our PSA density, that could point to the fact of what the prostate architecture is made of. So glands that are, prostate tissue that's more glandular is more likely to be receptive to tissue-altering techniques like Resume, while those that are more stromal component may require something where you have to actually enucleate or remove the tissue. So that's another place where PSA could potentially play a role, is helping us elucidate prostate architecture. This is a study that we did looking at prostate zonal anatomy. And we're looking at transition zone thickness and IPSS, as well as PSA correlates for prostate size. And what we found was that with an increasing size of transition zone volume and transition zone thickness, it correlated with higher, worsening quality of life scores, worsening IPSS scores, and higher PSAs as well. So the idea is that when you get these larger prostates, higher PSAs, they do correlate with worsening symptoms. So now looking at PSA velocity, does velocity predict the need for BPH invasive surgery? And this is an older study, but looking at basically 3 groups, looking at alpha blockers, looking at watchful waiting, and looking at those who are likely to progress on to secondary treatment. And ultimately, velocity did not predict a clinical progression of BPH. So as we see this PSA change over time, it doesn't necessarily predict those who would need BPH related invasive surgery. And as I had mentioned before, this is an older study from 2006. So and they only had 2 time points. But I mean, what we do find is that PSA as an objective marker does predict those with larger prostates, and larger prostates are those that are likely to have more BPH progression. But the velocity or change of PSA may not be as predictive. The last part that we actually talked about before as well is post-procedural PSA and bladder outlet obstruction. So PSA in the post-BPH setting has shown that enucleation procedures, simple prostatectomy, have the highest drops in PSA, order of magnitude around 80%. When we look at aquablation, TURPs, the drop is around 50%. When we look at ablation techniques and implants, the PSA is very not changed. So this obviously plays a role in telling us the extent of our enucleation or tissue removal, and it could be helpful in determining that. So what we learn here is that PSA is not just for cancer. PSA is predictive of prostate size. PSA can also help predict our prostatic architecture from glandular versus stromal tissue, and it can also help predict postoperative volume reduction. Thank you.